words and have a good idea of, be able to tell if it's a good study or a bad study. This is kind of the quick and dirty version of evidence-based practice. When I took evidence-based practice, when I was in school, it was an entire semester. So there's that much information to talk about with evidence-based practice. We're just kind of scratching the surface to help you be better able to judge a good research project or research design coming up. So we're just going to hit the highlights. A lot of it's kind of definition, but easy peasy. There's something else I was going to say. It's too early. Coffee hadn't kicked in yet. Learning outcomes, there's a few of these. I'm not going to read all those learning outcomes. Roles and responsibilities. So once we get into the definition of evidence-based practice, it's a conscientious and explicit judicious use. That's hard to say. Of the current best evidence in making decisions about the care of individual patients. APTA had a big push in leading up to 2020. They had this Vision 2020. I think it talks about it in the book too. That by 2020 we're going to be implementing evidence-based practice into everything that we do. So that was a big push from the APTA to get us to really understand it and be better at reviewing the research. So most of the time in the clinic, clinical decisions are going to be based on a systematic review of the research evidence, which means the best available at the time. And the best examples for that, and if you take nothing else from this evidence-based practice lecture, is that randomized controlled trials are kind of that gold standard. If you get a randomized controlled trial, chances are it's going to be pretty good. We'll talk more about that too. And then meta-analysis. Those are like the two best ones. So clinical decisions are based on the review of the research and the clinical expertise of the therapist. So their proficiency, their judgment, their clinical practice, continuing education, things like that. So you take in whatever the research is, best at the time, plus your knowledge of being a therapist, and that's kind of how we make our decisions. We also use patient values. So these are made up of what the patient wants. And a lot of times the therapist will do this at the eval. They'll say goals, they talk about goals together. So a lot of times, a lot of the common stuff you'll hear from patients is they want to get back out to gardening. They want to be able to get down on a knee, be able to get back up safely. People want to still golf and play tennis. So you want to try to incorporate some of that into your clinical decision making. Also, why evidence-based practice? We kind of already talked about it a little bit, but it helps us improve outcomes. If we have people that have done thousands of studies and we can look at those studies and say, hey, they've had great results doing this specific treatment, then we should probably try doing that treatment too. It's going to help improve outcomes for our patients. It's going to make us more effective as a provider, and it increases our credibility, but also the profession's credibility. So if people say, hey, physical therapy actually works, it's great. And also it helps us get better justification from insurances. So when we bill for certain things, insurance, sometimes they're looking for whatever excuse they can not to pay, right? So if we can say, hey, this is backed by research, look at all these things, this is why we're doing that, then they can't really have an excuse not to pay us. But if our cousin told us about a treatment that somebody tried on them in Malaysia or somewhere outside of the country, we're like, all right, we'll try that. Insurance will be like, I don't know about that one. We're not going to pay for that. So when we do evidence-based practice, when we're trying to develop a question, well-developed and well-constructed clinical questions contain 4 elements. They use the abbreviation PICO, which means the patient, intervention, comparison, and outcome. So we want to develop our question with the patient in mind and a specific intervention that we're trying to study, and then compare it to an alternative intervention, and then what was the outcome achieved. So that's kind of typically the research process. When they're developing their question, they want to use PICO to start their study and develop a good question. So 5-step process. Step 1 is ask the clinical question. So we want to ask an answerable question clearly defined and related to the clinical decision that we're trying to decide. So if we're trying to decide on a specific treatment for a total knee, we want to be specific about that and not just say, what exercises help people heal after a total knee? We want to say, hey, does terminal knee extension improve extension after a total knee replacement? Right? We want to be more specific with our question so that it's a better study. And then focus to clarify the target of literature search, which is exactly what that would be. So we already talked about the PICO. There we go with our first big peak. But patient, intervention, comparison, outcome. Step 2, we got to acquire. So we get the systematic literature review. All the evidence is collected that we're going to use, using books, journals, clinical protocols. The stronger source of evidence used in the systematic review is going to make it better. So you can get those from APTA, PT Now, PubMed is a good one, Google Scholar. And then when we were here for orientation, it seems like the library here has got pretty solid research to find journals and stuff like that. So that'd be another great resource. So articles are selected that are most likely to provide valid results. And in parentheses, we got randomized controlled trials. Again, the gold standard, whenever I'm looking for something, if I had to write a paper, when I'm doing my search on the website, whether it's your library resource here, PT Now, PubMed, whatever, when I type in my question, I also type in randomized controlled trial. So I don't even want to see the other stuff. Sometimes there's reasons for it, which I think we'll hit on in a little bit, but those are the big ones. So step 3 is we got to appraise the research. So critically analyze what was the design of the research study, what methods they used. We'll get into kind of sample collection and stuff like that. So using all the stuff we're going to talk about is what you would use to appraise each study. What methods and analysis do they use? Do they print clearly? Was it statistically significant? This is tough, actually. Statistically significant. And we don't touch on it in here, but that's the p-value for anybody that remembers statistics. I always look for that too. It's another good one. We'll talk about more of the stuff that we're going to use to appraise in just a minute. And then step 4 is to apply the research. So after you've collected it, after you reviewed it, make sure they used good methods, make sure it's a solid study, then we're going to take that evidence and apply it in our clinical practice. So then we start seeing if it's really working for our patients. And that's where step 5 comes in, is where we assess. Was this new technique effective, efficient? Did it do what it was supposed to do, like the study said? Any questions on PICO or the 5 steps? Easy peasy. So they talk about CPGs, clinical practice guidelines. APTA has a lot of these. That's where you would typically go to find them. At least that's where I would go. The clinical practice guideline is just a lot of other professionals already go through all the research, and they sit down and they test all the things. They make sure all the research was good. They find everything with the best scientific evidence. They compare notes and they say, yep, this is good stuff. So then they set up these guidelines. And they issue them to different places like APTA. And basically all that is, if you're having trouble, like what do I do for a reverse total shoulder? What's the best guideline? What's the best way to take care of that? You go to APTA, you type in reverse total shoulder, and then you can find some clinical practice guidelines to help get you going. All right, so now we get into the research design. Most research designs have common denominators. Statement of the problem, formation of that question using what? What do you use to formulate your question?
PICO.
There we go. Y'all gotta wake up. Let's go. I'm excited. Y'all gotta get excited too. All right. Formation of the question using PICO, collection of the data and analysis, and then conclusions. And that's, have you guys looked at a study before? That's kind of how they're set up. You got the abstract, we'll pull one up here in a minute. And then the methods, and then it goes step by step, basically highlights all of those points. So general concepts about research design is you have independent variables and dependent variables. Everybody remember that?
Mm-hmm.
What's an independent variable? In your own words, I know you can read from the slide.
The one that changes.
The one that changes. So it's the one that we don't do anything to, right? So it's the one that's not changed by other variables that we introduce. So if we're trying to see a new knee treatment, and we take one that already exists, and we give the one that already exists to our independent variable. Wait a minute, I'm talking something totally different now. I'm getting ahead of myself. Independent variable is standalone, right? It doesn't change. So like someone's age is the independent. What was I talking about? Hold on. I was talking about my knee. What was I talking about? I'm getting ahead of myself. All right. Independent variable is standalone. It isn't changed by every other variable that we introduce or that we're trying to measure. Dependent variable is something that depends on the other factors. So like a test score is dependent, right? Because your test score improves based on how much you study, how much sleep you got the night before. So independent is not affected by what we're doing. Dependent is affected. A hypothesis, everybody understands a hypothesis, right?
Mm-hmm.
That's a tentative and testable explanation of the relationship between two variables. So if we go back to studying, and independent variable is the age because it's not affected by anything. So we can make a hypothesis that age doesn't have anything to do with how well you do on your test. Or the more you study, the better you're going to do on your test. That's a hypothesis that we can make. So a research hypothesis predicts the expected relationship between the variables, like we just said. A null hypothesis states that no relationships exist between the variables. So like everybody's heard, if you watch too much TV, it'll rot your brain. So if I was to create a null hypothesis, I would say that regardless of how much TV you watch, your brain will not actually melt. That would be my null hypothesis, because I don't think it will happen. And then for the null hypothesis to be rejected, it means that we did see a significant difference. So if I said, hey, no matter how much TV you watch, your brain's not actually going to rot. And then we do the study, we measure everybody, we do MRIs and brain scans, and for 16 weeks we let people watch TV for 10 hours a day while the other group gets no TV. And at the end of that trial, the people that were watching TV had a loss of brain matter or something like that. So we would reject the null hypothesis. The null hypothesis is accepted if we let them watch TV for 10 hours a day, 16 weeks later, nothing changes. Then we accept the null hypothesis. So different levels of measurement, these are things you want to look at when you're assessing research design. Nominal scale just means name. So it classifies the variables, scores them into mutually exclusive categories based on a common set of characteristics. This is the lowest form of measurement. So if you're reading a research study and they're using nominal scales to do a lot of their measurements, you're already at a disadvantage. It's probably not the best study to be looking at. So here the example is you classify people as male or female, tall or short. If you were to do a study and take people from certain zip codes, that's still that nominal scale. Ordinal scale classifies or ranks variables in terms to their degree in which they possess a common characteristic. So that's a long way to say ordinal means order. So if we were to take one of those tests or fill out a survey where it's like, how often do you watch TV? And then it's rarely, or never, rarely, sometimes, and always. That's kind of that ordinal scale. So it's a little bit better than nominal, but still not great, because there's no way to say that there's the same difference between never and sometimes, or sometimes and always. Right? It could vary. So if I ask how often do you go hiking, people say never. Because they never go. Some people will say rarely, which means they go once a month, but some people say rarely means once a year. Or some people that say sometimes could be once a month. So there's no way to really tell there. so that's why it's not one of the best levels of measurement. Then we have interval, which ranks variables based on predetermined intervals. This doesn't have a true zero. So for interval, think about temperature. Like there's a 0 on the thermometer, but it's not a true 0 because we can go below that, right? It can be negative 32 degrees outside, right? So there's no true 0 point, but it does rank things in a line like a thermometer. And then the last one's ratio scale, and this is the highest, most precise level of measurement. This is where we rank everything based on equal intervals with a true 0. And again, think about height, weight, things like that, where how tall are you? It can be, I don't know, it can be, but it can be 0 inches, right? There is a point where there's that true 0, where you weigh 0. So this one's probably more precise than any of the other levels of measurement. So as you're assessing your study, taking into account what kind of measurements they use, they're using ratio, we got a solid study. Sampler. Everybody know what a sample is? Selection of people that we're going to use from the population. Typically they use small sample to represent a larger portion of the community. The best way that I like to refer to sample is you always hear about the polls. And elections coming up, people get ready to vote. So they go stand outside the polls and they grab 600 people as they come out the door. Hey, do you mind sharing who you voted for and which way or the other? And then they come out and say, hey, South Carolina is going to vote this way because we polled all these people in these different counties and this is who was winning. So they take that small group of people that they're asking and say, apply that to the whole community. So when we're taking samples, we have random sample, which means everybody has an equal chance to get chosen for the study. We just grab people. They go to the polling place and they start grabbing them as they come out the door. Hey, come here for a second. Next person, come here, come here, come here. A systematic sample is we're grabbing people at specified intervals. So we're standing outside the polling office and we're going to take every 10th person that comes out. So 10 people come out, all right, you come here. 10 people come out, you come here. We're trying to get a good understanding of the total population. Between those two, which one would you say is more likely to be a better sample? Grabbing everybody as soon as they come out or every 10th? You get more variety with everybody. You might, every 10th might be the same, and then we're missing all that in between. They're both pretty good, but I would say random is the best. And then stratified is where we're taking people based on a predetermined characteristic, based on their height, weight, gender. If we went to the polling place and everybody that came out after voting was wearing a MAGA hat, and those are the only people we chose, right? Because we're taking them by a predetermined characteristic. Do you think that's going to be a good sample for who the community is voting for? Why not, right? Because we're only getting one side of the story. So again, random is the best because you're more likely to hit on a variety of different people and things like that. And depending on the study, you may want a stratified, right? If we're trying to figure out who recovers faster from a total knee replacement, men or women. We don't want a random sample because that's just mixed men and women. We want to be stratified. So depending on what you're trying to study, depends on, so not random, just not always the best, right? It depends on what you're looking for. Does that make sense? So with our sampling, we have double blind, where the experimenter and the group, the sample, don't have an idea whether they're getting the intervention or not. So a blind would be the researchers know, but the sample groups don't know which group they're falling into. Double blind, neither the researcher or the group are aware of their group assignment. The effect size is basically just the size of the difference between the sample. So when we're looking at a study, what is the effect size? How big was the difference between the group we changed and the group we did nothing to? And then generalizability depends on how well that study relates to the entire population. So again, going back to our polling thing, if we grab randomly everybody that came out and asked them who they voted for, it probably has a good somebody say that. Generalizability. It's a hard word to say. That, if we were just grabbing people that had the MAGA hat, could we say that that's a good generalization of the population? So when we're doing our assessment of the research study, we want to look at what tools they use, what instruments were chosen. Best thing we can find is the gold standard. Gold standard just means that it's been proven time and time again through various tests and procedures to be the best way. It's got high validity and it's better. When we're coming up with a new way to measure something, we're going to compare it to the gold standard because that's the best. So how well does this new measurement add up to the gold standard? So gold standard instrumentation, and you can find a list of those. But here we get into more of the statistics stuff. Does everybody know what the mean is?
Mm-hmm.
Somebody shout it out. The average, right? So you add everything up and divide it by the total number, right? Easy peasy. What's the mode? The number that appears the most often. Yep. What's the median?
The middle number here, the sequence.
Yes, false. Right. Does everybody remember standard deviation? Remember the bell curve? How far things are placed from that median? So that's all. So a low standard deviation means that everything's clustered around the mean, not the median. And a high standard deviation indicates that it's more spread out. So when you're looking through your research design, you just want to be able to understand these words and what they're talking about. So getting informed consent. Anytime you're getting a sample, you gotta have that informed consent. So with specifically medical studies, we can forget about the polling thing for a minute. But in these studies, we need a document that's going to include everything that the individual needs to know before they start saying, "Yep, I'll do your study for you." So a lot of times, it's going to have information about the general nature of what's to take place. They don't give them all the details because then people are going to know what we're looking for. So general nature of what we're trying to do, any risks to that individual, and what we're going to do to minimize those risks, any possible benefits for them or for, hey, if you help us do the study, it's going to help us better treat the rest of the population, you can do things better with this, and then any ethical disclosures that you need to tell them about all have to be written up in that informed consent, and then they have to sign it before you can grab them and use them as part of your study. Alright, this is what I was talking about, control. That's the group not receiving the intervention. So, the experimental group is the one that we're doing the changes to. The control group is the one that's not going to do anything. So in our does TV rot your brain scenario, the control group is going to be the group that doesn't watch any TV. We're not letting them do anything. But the experimental group is the group that we're letting watch 10 hours of TV a day just to see. So they're the ones that we're actually doing something to. The other people just get to live their own lives. Does that make sense? And then intervening variables are variables that alter the relationships between the independent and dependent variable. These intervening variables are things that we don't have control of. So, like anxiety is the example here. So you can't control someone's anxiety. So, in the situation about TV melting your brain, if one of the people in the control group has anxiety, and the best thing that they can do is kind of watch some reels on their iPhone or something like that. You don't really have any control unless you have them in the lab. You know what I mean? So intervening variables are ways that we can't measure, can't judge, can't control. Right. Everybody hanging in there so far? So, talking about validity. Validity is the degree to which a test or a tool or an instrument measures what it's supposed to measure. Right? So, like a goniometer, right? You want to measure joint range of motion. How well does that device actually measure the joint's range? Pretty good, right? So it's a high validity. So with validity, you also have internal and external validity. These validities are talking about the research design itself, but they can be used for tools also. So internal validity is the degree in which the observed differences are a direct result of manipulation to the independent variable and not something else. These are ones to have a high internal validity, you have to be done in a lab where everything can be controlled. So then the only thing that's affecting your dependent variable is what we're doing in the lab. So an external validity is the degree to which the results are generalizable to the general population outside of the study. So how well can you take the things that you did in your study to the general population? So stuff with high internal validity typically has a lower external validity. Because if we're in the lab and we're in complete control over everything, and I'm making a change to this variable, it's going to be great. It's going to have a high internal validity because we did what we tried to do, and we know that there was a change because of what we did. But you can't take that to the general public because of those intervening variables. When you take it out to the general public, there's all kinds of other stuff that can affect what you're trying to change. So high internal is going to have a low external, typically vice versa. And then face validity is just the assumption that the instrument is a reasonable measure to measure your variable. This is just, we're taking like an initial screening to get them into a study. We're taking at face validity that that's a good study. You know, there's already been the research done, so we know that that'll work for this particular research. Content validity measures the degree to which an instrument measures the intended content area. And these are determined by expert judgment. And this requires both the item validity and sampling validity. So basically, is your research design looking at what we're trying to look at? Is the content valid? Concurrent validity is the degree in which scores on a test are related to the scores of another test, with both given at relatively the same times. Usually this involves comparison to the gold standard. So like SATs would be like the gold standard maybe for testing for general knowledge, whatever they use SATs for. But if we were coming up with another test, and does it test the same way, right? We're trying to figure out if it has that concurrent validity. If we test with a pre-test for a practice SAT and a PSAT, does that actually help with the SAT? Predictive validity just means the degree in which a test is able to predict the future. And construct is the degree to which a test measures the intended hypothetical abstract concept. So a construct validity, you're trying to measure something that can't really be measured, like ideas, beliefs, behaviors of people. You're saying, hey, if we do this certain thing, and it might affect the way people behave or the things that they believe. There's no way to really test that, treasure that. So it's a construct. It's kind of abstract. And they use those for research testings when they can't actually get a bunch of people together. They just kind of believe that if we do these things, this will happen. And there's that construct. Validity. Everybody doing okay? Okay. Take a break or keep rolling? Talk at once. Alright, let's go. So when we're determining the quality of the research, we also got to keep in mind what threats to the validity. So one of the most important things to know is bias. So the hierarchy of evidence, when you're looking at research design, bases the researcher's ability to minimize bias. So what is bias? You have sampling bias, where the researcher introduces error by getting a sample of convenience instead of a random sample. Failure to have complete control over the subjects and the conditions, meaning the intervening variables. And the example there is a longitudinal pediatric study where you're looking at a child for 10 years. Well, he's not a child anymore. He's not pediatric after 10 years, so you can't really follow him anymore and see how it changed. Just another example of sampling. And then administration of the pretest influences scores on the post-test. So you get that learning effect. So if we were testing range of motion on a shoulder to get them into this shoulder study that we're doing. And the pre-test is the same one that we used during the test. So they had to go through a goniometric measurement of shoulder mobility to get into this program, to get into the research. So now every time they know that they're trying to get more range of motion, so they push harder, they start cheating. So that's another way that we can have threats to the validity of a test. Or the measurement instrument's not accurate, where the test doesn't measure the characteristics that it's saying it's gonna measure. The example they gave here was muscle strength versus motor control, which are kind of two different things. You can be strong, you have good muscle strength, but you don't have control against like outside influences. And then pre-test treatment interaction, subjects respond differently to the treatment because of the pre-test. It's kind of similar to the last one we talked about, where they just learn the test and they start doing things that they think they should do. Because a lot of times people just generally want to make people happy. When they're in the research set, they just want to do the right thing. They want to do better, so that you get that learning effect, or they change the way that they're moving or doing because they've been exposed to a test already. And then multiple treatment interference, where you're having more than one treatment at the same time while you're trying to measure, does this treatment help? They're also getting treatment for something else. So you can't say for sure that yours is what made them better. Then we have experimenter bias, where the expectations of the researcher about the expected outcomes influence the results of the study. So if he's already going in and he's, hey, this is gonna change the way people move, then he's gonna see and look for things to say, yep, that helped, yep, that did it, when maybe really it didn't. The Hawthorne effect is just the subject's knowledge of participation in an experiment can influence the results of the study. And then placebo effect is where people respond to a sham treatment and say, yep, that worked for me. So like if you're testing if a pill helps lower blood pressure, you're like, man, I feel like my blood pressure's so low, but they were just taking a sugar pill. Right. Reliability is the degree to which an instrument measures accurately, dependably, time after time, and without variation. So we're talking about goniometers measuring joint range of motion. They're pretty high reliability. So when you put them on there and you line it up correctly and you move that joint, it gives you a really good reading of how many degrees that joint's moving. So they're pretty high reliability. Then you have, within reliability, you have inter-rater and intra-rater. Inter-rater is the reliability between two or more independent raters getting the same result. So if you take the goniometer, I think 2 or 3 degrees is like the inter-rater reliability difference with goniometers, right? So if I get on there and I measure shoulder flexion to somebody, and then Tatiana goes in there and measures shoulder flexion, and then David goes in and measures, we're all gonna have the same results within 2 or 3 degrees, which is pretty darn good. So inter-rater, think about interstates, right? They run in between more than one state. Inter-rater is more than one rater, more than one person doing the study. Where intra-rater measures the degree of how reliable is that when I do it multiple times. So if I measure David's shoulder range of motion, Tatiana's shoulder range of motion, Alexa's shoulder range of motion, how often am I getting a true good reading, which is great. And then you got test retest. That's the degree to which the scores on the test are stable or consistent over time, and it measures the instrument's stability. So can you use it again and again and again and again, and it's going to hold up and do the same thing every time? That's test retest reliability. Split half reliability is you're basically studying 100 people, you're applying this tool, using the goniometer. You take the first half, we take 50 here, 50 here, and then we compare it and make sure that it measured each the way that it was supposed to. So the split half didn't test this group just as well as it tested this group. And a lot of this is just talking about the reliability of the tools that you use during your research design. So some of the threats to reliability, we have errors of measurement. So when we're talking goniometer, 2 or 3 degrees reliability, solid test, solid tool, but you have to line it up right. You gotta line it up on your bony landmark, so you gotta put the piece that moves right over the joint. And if you're not doing that, if I'm way back here, if I'm measuring shoulder range of motion, but I'm holding my goniometer here, that's gonna throw it off by 10 degrees. So that's an error in measurement. You also have objectivity, where there's agreement among expert judges on what is observed or what is done. So this is like your licensure exam. It's a very objective test. They don't really care. They don't know you. They're not going to try to tweak any results to say, yep, you passed. So having objectivity with the reliability is huge. And subjectivity refers to a testing format that may differ depending on the person grading the test. The example here is figure skating. So like you have a panel of judges that are up there marking people off, taking points off for whatever they don't hit right. And one of them may think that, oh, this trick is the most amazing trick, and even though they messed up a little bit, I'm going to give them a higher rating because it's a hard trick. Where the other guy's a stickler, and he's like, nope, they messed up, they're losing points. So you have that subjectivity of the people measuring the test. Sensitivity and specificity. Sensitivity is basically just the ability for the test to identify people that do have the disease or the condition. It's a true positive. So sensitivity is how well the test actually measures people that are positive, that have the condition. And specificity is the ability of the test to report people that do not have the disease, a true negative. So when you're looking at a research, you want something that has a high sensitivity, but you also want it to have a high specificity. Right? So if my test is set up in such a way that I have a high sensitivity, but not a very high specificity, then I'm going to get a lot of positives, which is good. But there could be some false positives in there because I don't have a good way to rule out that they don't have the condition. Does that make sense? So sensitivity is how well you can detect if they have a condition or if they have that true positive. Specificity looks at the true negative. Does the test do a good job of making sure that they don't have that disease or condition or whatever you're testing for? So you want high sensitivity, high specificity. Those words, man. All right, so the predicted value is the test's ability to estimate the likelihood that a person will test positive or negative for the target condition. True positive, individuals correctly identified as having the condition. True negative, correctly identified that they don't have the condition. We have false positives where individuals are identified as having the target condition when they don't. You have false negatives where individuals are identified as not having the target condition when they do. So both sensitivity and specificity are expressed as values between 0 and 1. And values closer to 1 are what we want. So if you're looking at a test and the sensitivity is 0.95 and the specificity is 0.004, probably not a great research design, right? Because we're not able to really rule out people that do have the don't have the condition. Yeah. Does that make sense? Sensitivity, specificity. They can be combined to make a likelihood ratio, which is used to determine how much the test influences identification of a condition or limitation in function. You combine them together and it makes the likelihood ratio. Responsiveness is used to determine if a measure is sufficiently sensitive to reflect meaningful change in the status. You have minimal detectable change, which is the smallest amount of change in a measurement that can exceed the measurement of error of the instrument. So that reflects a true change. And then you have minimally important clinical difference, which is the smallest difference in the measured variable that signifies a clinically important change. So when you're doing a research design for PT and it has minimal detectable change, that's pretty good because it reflects a change in status. That's what we want. That's better. But if it has minimally important clinical difference, then that applies more to what we're doing clinically. So it's a little more specific. Evaluating the evidence. I don't know why this slide is in here. And I just didn't take it out. Has nothing to do with what we're talking about, but it's true. So it's the most appropriate feedback strategy for PTA to use when Providing exercise for a patient is occasional feedback when errors appear. I don't know how to say it. All right. So going into some of the trials. So we've talked about what we need to look at. We've learned some of the vocab words, things that we want to understand when we're trying to decide if the research was good or not. Now we're going to talk about the different types of research. We have systematic review, which is a literature review where the primary studies are summarized, critically appraised, and statistically combined. So they're usually quantitative in measure, which are randomized controlled trials, with specific inclusion and exclusion criteria. Meta-analysis is a statistical analysis that combines the result of multiple conceptually similar scientific studies, which results in higher statistical power and more robust finding. So systematic review is the next best thing for me in a randomized controlled trial, because they take a bunch of these that look at the same thing, and a group of people study them, and they talk about them, they compare the differences, and then they say, yep, all the stuff that they talked about is great. And it's all checks all the boxes, they eliminate bias, they've done their sampling perfect. So systematic reviews, and then randomized controlled trials are an experimental study in which participants are randomly assigned to either experimental or control group and receive different interventions or placebo. So this is one of the ones that does the best at minimizing bias, and the sampling is usually better, and that's why when they do a systematic review, they use randomized controlled trials. So if you take nothing else away from our EVP lecture, when you go look for stuff, look for one of these or one of these. A cohort study is a prospective study, kind of forward in time, where you follow a group of people with a similar condition. So you have a cohort study to see, does this drug help lower cholesterol? And you're going to take 200 people and you're going to follow them from the time they started for however long, 5 years, 10 years, whatever, cohort study. And then homogeneity and heterogeneity. Homogeneity is a systematic review of the variations in directions and degrees of the result between studies, where heterogeneity is a systematic review that has some variations. And this is just talking about when you're looking at the systematic review, you find stuff that's similar, and then these two kind of differentiate between this one has variations in degrees between the results, and this one just has some variations maybe with the research design. Those are weird. We're not going to have a test question about that. And then a case study is just descriptive research with one individual. This is typically what you find in all your textbooks and stuff like that. We follow a case study. We start with this person that had this issue, and we're just going to follow them along their journey with how they're progressing. Done. Any questions about any of that stuff?
So for the test, are they going to be like scenario based or like
Say that one more time.
The test, are they going to be like scenario based kind of questions or like definitions?
They're kind of a mix. With evidence-based practice, a lot of that is probably just like, a lot of this stuff is definitions and understanding what the words mean and stuff like that. I think there might be a couple in there with like an iterator, like what's the difference, things like that. Most of it's, and they're all multiple choice or like matching and stuff, so they have options. Any other questions on evidence-based practice? Again, this is just a real brief summary of the different kinds of study and the different words, just so you understand when you're looking at a research design, you can say, oh, I know what they're talking about. Oh, I know what to look for. Does that have high sensitivity and specificity? So I just want you to understand what those words mean, so that when you're doing research, you know if you got something good or not. All right, let's take a break. Kind of summary, right? Quick, easy, because I think in pathology we'll learn a little bit more about some of this. Dr. Christie does another class on wound care and things like that next semester, I think. So you get a lot more detail into it, which is kind of introductory to tissue response to injury. It also has a lot more learning outcomes that feel free to read, and an overview, feel free to read. We're going to start with pain perception. So pain serves as a protective mechanism. There's a definition here. We also did definitions in the lab. For those of you that have lab today, we'll talk more about definition of pain. But just just know that it's a protective mechanism. It's kind of almost like one of those primitive reflexes that we have from the caveman days where you're out hunting and you trip over a rock and sprain your ankle or break an ankle, and then you have that pain to say, hey guy, quit walking on your ankle, we need to head back to the cave because it's not good. It's kind of what pain does for us. So it allows the individual to be aware of potential for producing tissue damage and minimizing further damage. And it's also one of the most common reasons that people seek medical assistance. Probably the most common for people to come in. So they don't ever come to us when they're having a movement issue, right? When they have some limited movement, they just kind of deal with it until it starts hurting. So usually by the time people come to us, they've been in pain for a while. So for us, it helps us determine the location of the injury, behavior, and determining the stage of healing and the impact on the patient function. Pain can also be a sign of physical, physiological, and psychological dysfunctions. Pain receptors are referred to as nociceptors. They're just special receptors that signal actual or potential tissue damage. Nociception is the neural process of encoding and processing noxious stimuli. So, different types of nociceptors. We have a high threshold mechanoreceptor, or the little Pacinian corpuscles deep inside the skin that react to the higher levels of mechanical pressure. They respond to mechanical stimulation, and they travel on A delta fibers, which are fast. They are the fastest fibers, actually. So these sensations are well localized with a pricking sensation. We have mechanothermal nociceptors that respond to noxious heat, also travel on A delta, the fastest fibers, and sensations are well localized with a pricking sensation. And our polymodal nociceptors respond to noxious heat, irritant chemicals, and these run on the C fibers, which are the slowest fibers. And these sensations are poorly localized with dull, aching, and burning light sensations. Any questions on nociceptors? Pretty solid, pretty straightforward. Right. Biggest thing to remember there is A delta fibers are the fast, C fibers are slow. Over time, pain has a ton of side effects and issues. People get fatigue, insomnia, they get increased irritability, anxiety, depression. All of this stuff can come on, especially for people that have been in chronic pain. So on a local level, you get muscle guarding. So you have something going on, pain in your shoulder, and your muscles start to guard or spasm, which causes there's more edema, there's more swelling. You get some ischemia. Anybody know what ischemia is? Yeah. The blood flow. Decreased blood flow. So with all that swelling, the muscle gets spasm, and there's not a lot of blood flow going on through there. And so with that, you get a release of the endogenous pain mediators. So the potassium, serotonin, brain, histamines. All of these guys are the little chemical mediators that when you're having some pain, they go up to the brain and say, hey, this hurts. That's really all that is. So on a systemic level, you start firing up the sympathetic component of the autonomic nervous system. So you kind of end up in that fight or flight. So this involves a lot of body systems. Usually have increased heart rate, sweating, expansion of the bronchioles, dilation of the pupils, shunting of the blood from the skin and digestive tract to the muscles and brain. So when we're in that sympathetic is our fight or flight. And that's kind of some of the stuff that you get with that fight or flight. The parasympathetic is known as what? Rest and digest. So when that parasympathetic is more active, then you're getting stuff to the skin and digestive tract. When we switch over, everything moves to the muscles and brain because that's fight or flight. I broke my ankle, but here comes a lion. I gotta run, right? So everything goes to your muscles. So throughout the day, we should be on like a pretty even up and down of sympathetic, parasympathetic, sympathetic, parasympathetic. Your nervous system kind of goes back and forth throughout the day. But people that are more fatigued, not getting good sleep, having increased irritability, having some decreased appetite, all this is going to put us in sympathetic. There's no back and forth. So a lot of times, people that have chronic pain are just always in that sympathetic part of the nervous system. It's always on, always fight or flight. It's just something to remember. So when we get into that state, we start to experience what we call hyperesthesia, which is pain that's produced from normally non-painful stimulus. You see that all the time in the clinic. People that have been in chronic pain, they got low back pain, pain from their low back down to their knee or to their ankle. It's always there. There's nothing they can do about it. They take medication and it helps a little bit. So when you get them in the clinic, you're all right, well, let me palpate around that, and then you just touch them, just a light little touch, and they're jumping off the table. So that light little touch shouldn't cause that pain. They're having that hyperesthesia because of that systemic, constant chronic pain and fight or flight. So this is our pain perception cycle, where we have a pain and we release some of those chemical mediators to the brain to say, hey, we have pain, and then we get some muscle guarding, and this is all the stuff that's adding to that. We get the decreased circulation, decreased oxygen, decreased nutrients. All of this stuff is affecting and contributing to a little bit more of this, which causes more guarding and muscle spasm, which causes a dysfunction in your movement, and that dysfunction in your movement causes pain. So then the pain causes the muscles to guard, and you see how we just get stuck in this. And that's kind of like what's going on with chronic pain. You just get stuck in that cycle. And you hurt, so everything tightens up your guards, and you get all this stuff that happens, decreased blood flow, all of that causes dysfunction in your movement, which then causes pain, and it just goes on and on and on, like the song that never ends. Does anybody know what I'm talking about? Okay. Just checking it out. So for researching pain, you have our normal pain that we were talking about, then you have experimental pain. And this is pain that is induced to study the physiological, psychological, emotional behavior in response to stimuli. In the real world outside the laboratory, the variation in relationships between pain and injury occupies all portions between injury with no pain and pain with no injury. Experimental pain does not have the psychological components to deal with that are commonly associated with the clinical pain syndromes. So this experimental pain doesn't help us much in our profession. It's a thing, they do tests, but the tests are usually done to kind of give us some insight on pain pathways and things that we still don't understand about pain. And we don't deal a lot with experimental pain. We deal with the real stuff. And this is just showing you kind of the difference in clinical pain versus experimental pain. You have all these factors that go into how people perceive and how we deal with clinical pain. Where here, it's a little more controllable. We can localize it. We can make it phasic, tonic, make it superficial or deep. So we have a little more control while they're studying stuff here. Where out here, we don't have any control of that. Just kind of talking about the differences. So going with our nociceptors again. There are terminal portions of the two types of afferent. Everybody know the difference between afferent and efferent neurons? What are afferent?
Afferent means like going towards, and deferent means going away from.
Yes. So afferent, we get a poke or a stab or a prick, and those afferent A delta fibers signal that sharp and localized pain into the dorsal horn of the spine, jumps on the T cells, and goes all the way up to the brain, which then sends down the efferent response to move your hand. So efferent. So A delta is transmitting the detailed information rapidly from the peripheral cutaneous structures, and the C fibers transmit information from the deeper tissues, the joints, the viscera, and they do it a lot more slowly than the delta fibers. These are usually dull, aching, diffuse pain signals. So the crossing over the cells prior to ascending is one of the reasons that the sensory stimuli at the spinal cord nerve root can help either side with pain reduction, because they go through the nerve root and then up to the brain. And And I just show you that ascending pathway at the bottom. So A delta fibers transmit discriminative touch stimuli from the skin. So they're sensitive to crude touch, pain, temperature. They transmit fastest. Pain sharp, stabbing, tingling, or prickly. It's quick onset, lasts a shorter amount of time, and is more localized. And it's not affected by opiates. So the C fibers are slow transmitting. The pain's usually dull, throbbing, achy. It's harder to localize it. And this is the one that's more associated with the increased perspiration, heart rate, blood pressure, nausea. And this is best reduced by opiates. You got wide dynamic range cells. They contribute to the localization of the burning or prickling pain, as well as discrimination between touch and obnoxious pinching. This is stimuli produced by motion. So when you think wide dynamic range cells, think about motion. They receive input from both the viscera and the skin. And these are also called T or transmission cells, and they form the basis for the gate control theory, which we'll talk about in a minute. So we get those A delta fibers come in from the skin, go through the spinal cord, and they go in and they talk to the T cells and say, hey, this hurts out here. And the T cells scatter and they go up the chain and spread that information. The descending pathway is the inhibitory pathway. So descending modulation of pain perception is thought to block the pain signal transmission in the dorsal horn of the spinal cord. So sensory discriminative is a dimension of pain perception localized around the source and type of pain. A non-painful sensory stimulus, which is transmitted by A beta nerve fibers, is also thought to block pain signal transmission in the dorsal horn. All right? Everybody following along so far? All right. So when we go up the pathway, the peripheral first order C and A delta afferents enter the gray matter of the spinal cord. They synapse either directly or via interneurons with the second order neurons, or T cells, in the superficial dorsal horn of the gray matter. And when these centrally projecting axons reach the dorsal horn, they branch into ascending and descending collaterals, forming the dorsolateral tractive lissura. I'm not going to ask you about the tractive lissura. I just want you to understand how they kind of flow. You get the pain signal, it goes into the dorsal horn, they meet up with the T cells and say, hey, something's going on out here, and the T cells kind of scatter to the next nerve root level and work its way up. So they make connections with the spinal cord with the efferent neurons, reflexes, and the afferent neurons that project to the cortex. So the T cells are kind of talking to everybody. So the pain transmission comes in, you go to the dorsal horn, you meet up with the T cells and say something's going on. T cells kind of scatter. They talk to the efferent neurons and say move your hand, and then they go talk to the brain. The brain says, ow, that hurts. It all kind of happens like that. So the inhibitory interneurons in the substantia gelatinosa are activated by input from the large diameter myelinated low threshold sensory neurons, which are at A beta. And they respond to non-painful stimuli. These neurons release the neurotransmitters norepinephrine, serotonin, that helps block the pain signals, also helps us release those enkephalins. And all of that helps us reduce the perception of pain by bonding to the pain receptor sites. So it's kind of like using those A beta that respond to non-painful, and they go in and they get processed in the dorsal horn. It's kind of like if you're hammering a nail, you're doing something on the wall, right? And you hit your thumb with the hammer, and that hurts. And everything starts moving and talking, but then usually what's everybody's first reaction when they hit their thumb with a hammer or they stub their toe? Everybody grabs it and hold it, right? That's those A beta non-painful. So we're getting that deep mechanical pressure. We're touching that, and that goes in, and the brain starts processing that. That's why it helps the pain not feel quite so much. Does that kind of make sense? All right. Any questions on how that pain pathways and nociceptors? Okay. If you have questions, please ask me. So, different types of pain. We have acute pain. What's acute pain? everybody. Acute pain is just when I hit my hand with a hammer, right? That's acute, just happened right now. That's acute pain. So it's associated with tissue damage or the threat of damage, and typically resolves once the tissue heals or the threat resolves. Acute pain is often associated with the physiological signs of distress, such as sweating, pallor. Everybody know what pallor means?
Color drainage.
Say that again?
Like color drainage.
Yeah. Loss of color, nausea, heart rate changes. All that's associated with our acute pain. Recurrent pain is repeated episodes of that acute pain. So like a low back strain, or there's another example of a migraine. A lot of this is if you're out playing tennis and you go for a ball and you strain a hamstring or something, right? That's acute pain. You just strain a hamstring, that's acute. And maybe some tissue damage, maybe not, but potential. So that's acute pain. So then you walk it off, you stretch it out, you finish your match, hamstring's feeling great, you go home, you go to walk up the stairs, and it starts hurting again. It goes away after a little bit, and you go sit down for dinner, and you sit down, it starts hurting. That's recurrent pain. Okay? So just repeated episodes of that. Make sense? Then we have chronic pain. Pain persisting more than a specified length of time. We're just going to say 3 months. Pain after 3 months. I don't know why it says 3 or 6. If it's 3, then it's 3. So we're going after 3 months. That's how I learned it too. So chronic pain is pain that lasts for longer than 3 months. Another definition of chronic pain is long-lasting, persistent, sufficient duration and intensity to adversely affect the patient's well-being, function, and quality of life. We see a lot of people in chronic pain in the clinic. It's often not well defined or easily to localize because the nociceptors commonly transmit stimuli from the nerve root through several different segments. Like we talked about when we have that pain perception and the nociceptors and those delta and C fibers come into the dorsal horn, they talk to the T cells to say, hey, something hurts. We don't like it, and the T cells kind of scatter and go different. They move up to the next nerve root, and then they go up and they work their way up. So people that have been in chronic pain have had those signals going for so long that the nerve roots kind of get a little mixy sometimes, and it's hard to really pinpoint where it's coming from. People stay in chronic pain long enough, they develop something that they call chronic pain syndrome. And these people end up having preoccupation with their pain, a passive approach to healthcare with significant life disruptions. They start feeling isolated, they start doctor shopping. So these people don't want to do anything. They want something done to them to help their pain. These are people that are hard to deal with in the clinic because they've been in pain for so long, they've almost given up all hope. They're completely preoccupied with their pain. They don't want to go out with their friends. They stop doing anything because I can't do that, it'll hurt. I can't sit at a restaurant with my best friend who's in town I haven't seen in 20 years. I'm just not going to go because if I sit at a restaurant, my back's going to hurt, and then I'm going to be flared up, and then the next day is going to be miserable. That's people that are in chronic pain. We hear it all the time in the clinic. So we got to try to do some stuff to help that too. And then they start doctor shopping because they just want the pills. I don't want to do therapy. Therapy doesn't work. It doesn't do anything. It makes me hurt. So I just want to go to the doctor and get some pills. And I'm going to find a doctor that's going to give me some pills. It's typically what you're running into. Referred pain, pain that arises from deep body structures, but it's felt by another distant site through a dermatome. Everybody know what a dermatome is? So like C1, 2, 3, 4, 5, they all kind of go down a specific pathway. They innervate myotomes, which are specific muscles that are innervated by that root nerve. And then the dermatome is just the areas of skin that also are innervated by that. So referred pain kind of rises from some deep body structures felt through a distant site. So if I have a C7 impingement or something going on in my neck, then I can get that referred pain down that side of the arm where C7 runs. Malignant pain is just pain that's associated with cancers. Nociceptive pain is pain that arises from the actual or threatened damage to non-neural tissues due to the activation of the pain receptors. That's everything we just talked about. Psychogenic pain is an older term believed to be caused by psychological influences when there's no organic complaint that's severe enough to justify them being in pain. So with that, pain has sensory and psychological components that complicate its accurate qualifier, right? So there's too many variables to give us. We know that there's sensory and psychological. We know there's physical and psychological components to pain. but it's hard to establish a set percentage. You know, some people that have labs, we've kind of already talked about that, right? It's hard to say if it's 50-50, 80-20, because you don't know, and it varies between person to person. And then here we go with the repeat slide again. Let's get that. Then we get into the management. So, analgesia is the absence or lessening of pain or noxious stimulation. Anesthesia is the loss of sensation, usually by damage to a nerve or a receptor. Lidocaine is an example of drug that you can use to get that loss of sensation because it's blocking the nerve. So the biggest difference to know there is analgesia is pain perception, for anesthesia is complete sensation, everything. So our goals during management of pain is to resolve the underlying pathology causing the pain, modify the patient's perception, maximize function within the limitations of the pain, and then get the underlying condition fixed, maybe bad posture, whatever it is, using some exercises. One of the therapists I like to listen to, he's got some podcasts. I've done a lot of CEs from this guy. He's in Boston. His name is Mike Reinhold. He's pretty awesome. But he was talking about this in one of the courses I took with him. He describes it as the pebble. So like if you have a pebble in your shoe and you're walking, and every time you walk normal, you step on that pebble and it hurts. So pain changes the way we move, pain changes function. You're stepping on a pebble, so the next thing you do is you start rolling your foot in a way that you don't step on the pebble, right? So now we're changing the way our ankle mechanics are moving, the knee, and I start walking like that for so long that now my hip, my low back are hurting because I'm putting all this strain on here because I'm walking funny. So now I go to physical therapy and say, hey, my hip and back hurt. And then they work on your hip and back. We get it feeling better. We do some massage, soft tissue. We get it loosened up. We do some exercise to strengthen the hip. Man, my hip and back don't hurt anymore. PT's great. I leave. I'm still walking to avoid that pebble. I forgot about the pebble. I'm still walking for me. So after a few weeks, a few months go by, my hip and my back start hurting. So his whole point is when we're treating, we got to find that pebble. Okay? So we got to treat the underlying pathology. What is causing the issue? So just a little tidbit, something to think about when you're out there and you're working as a PTA. You got to look at everything. Yeah, they're here for their hip and low back, but could there be something else going on? Let's follow that nerve. Let's follow the mechanics. It's not a test question, just sharing. So we just said that. There's a repeat, just for you, Natalie. All right, so we have narcotic analgesics, which are the opiates. And they use those to treat and prevent severe pain. This acts on the central nervous system to depress the brain's perception of the pain. They're also physically addictive. So those you get your Lortabs, your Dilaudid, morphines, Oxy, Percocet. A lot of adverse reactions for that is drowsiness, lightheadedness, blurred vision, nausea, upset stomach, dry mouth, and the biggest one is constipation. So we know that people that are in chronic pain already have less rest and digest. Their digestive tract's already not functioning great. And now they get on these opiates that also cause constipation, nausea, upset stomach. So that's one of the big things that you'll see that people that have been on long-term opioid use is it's really not comfortable for them in many ways. And then we have non-narcotics, and these also treat and prevent muscle and nerve pain. Lyrica, gabapentin, those are more nerve related. And then we have the Tylenol, Tramanols, the NSAIDs that block the inflammatory process and kind of mediate those bradykinins, which are some of those mediators that we looked at early on that send a signal to the brain to say, hey, we're in pain. So we can kind of decrease the number of those that are going around with NSAIDs. NSAIDs are another one that leads to a lot of GI issues because it tears up the linings of your stomach. So like taking ibuprofen or something every now and then when you have a bad headache or when you strain something, no problem. But if you start taking 4 ibuprofen every morning, and then you get home, you have 3 or 4 more before bed just to try to keep off of that pain. Long-term use like that tears up your stomach, your GI system, you start having issues with that too. But they can also cause the dizziness, change in balance, shakiness, and swelling. And then just a note that because pain is perceived by the patient, it appears to arise from areas of referral and not the deeper distant structures. It's important to be able to explain to them why you're not treating where it hurts. So like sciatica is a big one. People always have pain down their leg, maybe into their knee, maybe all the way down. The pain's in their leg, but then the therapist does an eval, boom, boom, okay, sciatic nerve pain. It's coming from this nerve root, like 405, or piriformis syndrome, where the piriformis has gotten so tight and it's pressing down the sciatic nerve. So even though their biggest complaint is more around the knee, you're probably going to want to work on the source. So being able to explain that, so using some of the stuff that we're talking about in here today about the referred pain and the way people process pain and things like that, I use it all the time in the clinic as I'm working with people to help them understand this is why I'm doing what I'm doing. Even though I know your knee hurts, let's try this, see if your knee pain gets better. And then kind of get in there. But if you're not educating them, if they come in and they're telling you my knee hurts back here, maybe sometimes in my hamstrings, a little bit back of my leg, and then you're constantly working on their low back or hip or something else, they're just gonna feel like you're not listening to them. This therapist has no idea what they're doing. I'm gonna go somewhere else. Right? So being able to educate about some of this stuff is huge. That's why it's so important to know it. All right, so pain assessment. Subjective, difficult to measure. Everybody's pain is different. If I walked around and smacked everybody with a hammer, using the same force on the hand, calm down, people would be out, right? They're done. Day's over. And some people would be like, man, it didn't even hurt. Are you gonna hit me, bro? Right? So people perceive pain differently, right? So it's hard to measure. And that's why there's so many different pain measurement systems. So we want to try to identify biological, psychological, and social factors that contribute to the patient's experience of chronic pain. So especially with chronic pain, these are the three factors. I just had this conversation with a patient this week, maybe last week. With any problem, but specifically pain, you want to treat it biopsychosocial. So we know those chronic pain people start feeling hopeless, and they stop doing things. And like we said, oh, my girlfriend I haven't seen in 20 years is coming into town, but I can't go because I'm sit in the restaurant, it's gonna flare up in pain. So they stop doing things that they like to do. Social. That takes a huge effect on their social life. Now they have no social life, and then they're constantly just preoccupied with their pain. That's all they think about. They wake up in the morning. First thing is, I can't get out of bed because I feel okay laying here. If I get up, it's gonna hurt. That's where that psychological component. So yeah, we do the biological, but I talk often to my chronic pain patients about these other two things and how to help them. There is a clinical psychologist that is great. Her name's Dr. Rachel Zofnis, and she has a website, it's just zofnis.com. She's been on several podcasts. She doesn't have any of her own. I do follow her on Instagram. She's always posting it. But this is her baby. This is her obsession, is getting people to understand biopsychosocial benefits of treating chronic pain and things like that. She's got a lot of cool stuff. If you're bored or on your drive, you want to listen to it, go to the website, find one of those podcasts she was on. It's awesome.
What'd you say her name was?
Rachel Zofnis. Zofness, I think. She's great. She's talking about how when she's got a workbook. I actually have the workbook and I made copies of it. I'll bring it in. I should have brought it today. I'm a bad teacher, sorry. But she's got a workbook that I use with my patients that tells you how to work through some of these components at home. So as part of their HEP, I'll make copies of the different little workbook things from her pain workbook and have them work on it, because we can't change pain, and that's her big thing, if we just do this piece. If we just take the drugs, if we just do therapy, we're not going to change the chronic pain that these people have been in for years and years and years and years. We've got to do these other two pieces. So she's great. The podcast, you should listen to it. It's pretty awesome. It talks about how much control our brain has, how much our psychology affects the physical. And she went to one of these other pain doctors that gave her some little thermometers that are plugged into a machine that reads body temp, and she's holding them. It's 98 degrees or whatever, right? So she's sitting there, and he's like, all right, close your eyes. We'll do like a little meditation kind of thing. So he's walking her through, and you're out in Antarctica, and you're hiking, backpacking. It's frigid. And he's doing all this description, and then the computer measuring her starts lowering her body temperature, right? And then he's like, oh, but finally we made it back to the base camp, and we take our gloves off, and we're right by the fire, and you got your hands right next to the fire, and it's so hot. And then your body temperature went up past 98 degrees, right? So it just shows how much change we can make physically, psychologically. So, if you're interested, give one of those podcasts a listen. They're pretty good. So, our goal is to identify all of those things, find their pain before the limit in tissue. Right? So this kind of gives us an idea of where they're at in that healing phase. So like if they're having pain before the tissue limitations, that indicates that the injury is still in the inflammatory or early granulation phase of tissue healing. We're going to talk about that stuff in just a minute. But pain before you reach the limit. So moving someone's shoulder and it feels free and easy, it's no problem, but then they go, ow, and it still feels like they got more to give, then that lets me know that they're still in that inflammatory or at least the early granulation phase. Things are still healing, so as you get to that certain point, it puts pressures and tensions on things and they don't like it, but there's no real limitation. But then if we get to where the pain occurs concurrently as we reach that limitation, so they're moving free, and then I feel it starting to kind of tighten up a little bit. They're not fighting me, it's just tightening up. And that lets us know that we're in that granulation phase, right? So things are actually starting to heal up a little bit. We've got some scar tissue developing, that's why we get that little sticky spot. And then if pain occurs after the tissue limitation, that lets us know we're remodeling, we're in that maturation phase. They can tolerate more aggressive stuff. So I'm pushing them up, and then I start hitting that kind of sticky spot where it's feeling stuck. And usually when I'm in the clinic, I'll get to that spot and I'll stop and I'll look at them. And usually they go, that doesn't hurt, I don't feel anything. Ooh, feels some more. So that's when they're ready to start taking it to that next level. So measuring pain, we already talked about, it's really hard. We're just gonna go over a couple of the different pain measurement scales that people use in the clinic. There's probably hundreds of them. Maybe not that many, but there's a lot. So one of the common ones though is the McGill Pain Questionnaire, MPQ. It measures both their perception of pain, gives them the body diagram for locating their pain, and then it has descriptive words, right? And then the pattern of pain. So some of the advantages here is we have a quantitative and qualitative. So you hand them this, it doesn't have the red stuff, but it has your key here. So they can come in and say, this looks like a sciatic type situation. So kind of low back where it's dull and achy, and then we get some of the numbness and tingling along with dull ache all the way down the leg. So that gives us an idea already, just looking at their sheet, like, oh, they probably have some sciatic stuff going on. So that's a great questionnaire. And then we have the visual analog scales, which is not as sensitive as some of the other ones, but it's just a quick, easy one. So you give them a piece of paper, 0 to 10, and you ask them to mark the line where they're having the intensity of pain at that moment. So this is good to use. You start treatment, pain is right here, boom, they mark it. We start doing some modalities, we start doing some exercises, some stretching, how you feeling now, they can mark it here. So it gives us a way to kind of mark as we're going through. And then the numeric pain rating scale is a variation of the visual analog scale, which wasn't even in here. It was, okay. We just talked about it. I'm losing my mind. So, patient asked to rate the pain from 0 to 10, 0 being no pain, 10 being the absolute worst pain imaginable. You can't even stand here and talk to me right now. You've got to go to the hospital because you're dying. So, they get that, they look at that, and they can say, I'm a 4, or I'm in between a 4 and a 6. And you say, okay, so 5, right? But that's usually what we do, is just the numeric pain rating scale, right? Just give me 0 to 10.
So none of these pains are good for chronic pain individuals. Because your definition of pain is not good. Like I have rheumatoid arthritis. My pain scale is going to be a lot different than most.
Exactly, and that's the whole point. Is
None
like,
of those scales are going to be accurate at
right,
all.
and that's the whole point, and that's why there's 100 different ones, because everybody perceives pain differently, right? So we just got to find the best one to use for you or for that next person. And a lot of this too is you got to qualify it. Like, okay, yeah, you got, all right, you got pain constantly. How is it today? Is today a good day or a bad day? It's usually how it started, right? When you woke up this morning, how was everything feeling? Your joints a little achy, or you feel, oh no, not too bad today. All right, well, you came here. How are you feeling today? 0 to 10, where are you at? What are you talking about? Yeah, oh, I don't know. It's hard to say. What are you on a bad day? On a bad day when the heart is really acting up, what would you rate that pain? Oh, that's like a 7, right? Okay, cool. How you feeling today? So we can kind of qualify it a little bit too, right? Does that make sense? Any other questions? Yep.
How do you assess when someone, like, say you like warm someone up on the machine, you're just like, hey, how you doing? How's your pain? Like 0 out of 10, and they're just like, yeah, it's a 10.
Just roll with it. I mean, I try to educate a little bit, right?
Uh-huh.
Like, hey man, a 10 means like you can't get out of bed, like you need to go to the hospital. Like something's probably actually wrong with you.
Mm-hmm.
At a 10, like that we can't help, right? And then they'll be like, I'm 10 all day. Just like, okay, right? What else are you gonna do? And if you can see, right, if they're not pouring sweat, if they're not like out of breath, you know, all those symptoms that we talked about with that, we know they're not a 10, but that's how they feel. That's how they're perceiving that pain right now. So you just gotta roll with it. Does that make sense? All right. Let's go ahead and take a break before we get into this. I don't want to be halfway through this and just stop. For the weekly assignments for the study guide, those were already kind of part of that course when I took it over. So I was just going to take them out. You don't have to turn those in. You don't even have to look at it if you don't want to. I left it in there because it is good stuff to look at terms. All that stuff that we talked about today, a couple extras, looking that stuff up. So it'd be good study stuff, things to look at, the discussion questions are okay. It's not a bad idea. Ask each other a couple of those questions. Look at those. So I think that's good study material to test yourself and your knowledge and kind of work together with some other people. I left it in here. If you don't want to look at it or think about it, it's completely fine. But I left it there, and it's like you only did it for the first 4 or 5 weeks, and then there's no more anyway. And I think a lot of that's just because this first few weeks, the tissue response to injury, the evidence base, there's a lot of definitions, a lot of stuff there. Whereas we get more into the modalities, it's more about that machine and the treatment and use of that. So that's seemed more straightforward. And maybe that's why they only did it for the first few weeks. I don't know. But I just wanted to point that out. That was one of the things I meant to do at the top of class, and I forgot about it. So week 1, 2, 3, I think it goes through like 4 or 5. So it's there if you want to use it. If not, don't worry about it. The quizzes are there each week, and they open up at 1 o'clock on lecture day. I said that right? Just reminding you. 1 o'clock on lecture day, those will open, and they stay open until 10 p.m. on Sunday. If you don't finish it by Sunday, sorry. You have plenty of time. It's open book. Let's go talk about some theories. Why you start? I'm bad at computer stuff. How do I start? Somebody help me out. This one? Yes. Summer? Okay, just check. Alright, I got the first row. Next one. The second row. Alright, so we ended up talking about some of the pain theories. A lot of the theories are kind of what we use to base our treatment of pain on, especially the gait control theory, especially as it refers to or relates to modalities. Can you hear me back there? Okay, just check. You move further away, so I'm going to make sure I was still projecting, but I don't want to yell at these guys. Right. So we have the limbic system. The limbic system is memories of past experiences and are a component that creates one's pain filter. A good way to think of the limbic system would be like if I was out hiking, strolling through the woods, having a great day, and I stepped on the tail of a snake, and he turned around and bit my leg, and it puffed up. I had to go get all antibiotics. I was in pain for like 2 months. Swelling finally went down. So like a year goes by, and I'm like, all right, going back out on the trail, let's go. And I'm walking down that trail, and I step on a branch that fell off of a tree. And when I step on that branch, a piece of it comes up and catches me on the leg. I immediately have the worst pain ever, right? My leg's about to swell up. It's going to hurt for months. until I look and see that it's just a twig, right? So my memories of my past experiences are what created some of that pain, right? And then I looked, it was just a sting, it's all good. And so that's kind of how you think of that limbic system. If that makes sense for everybody. Then we get into the gate control theory, which is where we talk about stimulation of the A beta. Which ones are A beta?
Fast.
A delta.
Oh, wait.
A delta is the nociceptors. What is A beta?
Oh, God.
Remember we hit our hand with the hammer and we grabbed it because those A beta nerves feel that touch and sensation and it helps decrease that pain a little bit. So stimulation of those causes inhibition of the T cells, which close the gate to the cerebral cortex. Right? So that's basically the gate theory in a nutshell. There's a lot, here's a diagram on the next slide. But the gate control theory literally just means that I hit my hand with a hammer, it hurts, I grab it, and I stimulate those A beta cells, right? They're non-nociceptive that feel the touch, right? The mechanical receptors and things like that. So they feel that. That goes to the dorsal horn, it blocks the T cells. So the A delta, those pain fibers are shooting towards the dorsal horn, and then I grab that, send those over there, they get there and they block the communication between those A delta and T cells. So now the T cells aren't spreading that information around and creating more of those release of pain modulating chemicals and things like that. So that's the basic theory for the gate control. So closing the gate to the cerebral cortex so we decrease the sensation of pain. What's that got to do with modalities? We use that theory to put some E-stim on somebody, right? Because now they're feeling that vibration, they're feeling that. We put a hot pack on, they're feeling that heat. Those thermal mechanoreceptors are kicking in, and they're kind of blocking the communication with those T cells so that pain gets decreased for a little bit. Why is that important? Because when we have that chronic pain cycle, we have pain that causes the muscle guarding and all the inflammatory stuff that's adding to that pain, and then it causes dysfunction, which causes pain. And now we throw in some heat and some E-stim. We kind of block that cycle for a minute, right? So the muscles get a chance to relax or maybe come out of that sympathetic for a minute, right? So that's the whole point of our modalities, a lot of times, not always, is to help decrease that pain. Does that all make sense? Here's a picture if you want to look at it. That's the A betas, our hot packs, ice massage, or whatever our modality is to come up here, close that gate so that these guys can't get up there as fast. Endogenous opiate theory. We talked about this in the lab for those that have already had the lab. If not, we'll talk about it some more today. And you guys will have an advantage. And the questions at the end are going to be so easy, we'll be out in 30 minutes. Kid bet. So the body produces morphine-like peptides, which are known as the endogenous opiates, that help inhibit the transmission of pain. Intense exercise, acupuncture, intense pain are all stimuli that help result in the liberation of the endorphins, which are opiates. That's where you get like the runner's high and things like that, or if you work out really, really, really hard, you just feel like that euphoria, right? Like, man, great. You just worked your butt off, but it feels so good, right? That's because those endorphins are going out and they're blocking any of those pain signals. And then the pain control theories, secondary pain approach is to target the perception of pain, which we just talked about with that gate control theory and some of the other stuff. Then we have the enkephalins, either of two polypeptides that bind to the morphine receptors in the central nervous system. They have opioid properties, but for a relatively short duration. So the enkephalins kind of respond to that list that we saw on one of those earlier slides when we have the pain and it releases the bradykinin and the histamines and all of those things that are on there. I can't remember all of them. Those guys get released, so then these enkephalins also get released in response to that to help moderate that a little bit and decrease some of those pain-inducing chemicals. Endorphins work much the same way. They bind to the opiate receptors and found mainly in the brain. Endorphins reduce the sensation of pain and affect emotions for a longer duration. All right. inflammation, body's response to injury. These are your cardinal signs of inflammation. I don't know why they put the Latin on there, but there you go. Anybody that's interested. But the biggest things for inflammation, we have heat, usually we kind of warm. We have capillary permeability because of Hagen factor. We release that histamine and bradykinin, which is what we just talked about. You get redness, where that basically what that means is redness in response to the injury. You have swelling because of the increased capillary hydrostatic pressure, and usually you have pain, which results in loss of function. So big thing is inflammation is heat, red, swelling, pain. Primary response, we have that tissue destruction. It's associated with a traumatic force, and we can't change the amount of initial damage. But prostaglandins are produced by nearly everybody in the cell, and those are another one of those where we talk about the histamines and bradykinins and all those pain-inducing chemicals that we talked about way back then. That was one of them. And it's produced by nearly every cell in the body, but they're inhibited by both NSAIDs and steroids, which is why we take ibuprofen and other NSAIDs, because it helps lower that prostaglandin production, so do steroids. So they're released in response to damage to the cell membrane. They control some of the pus that contain large numbers of white blood cells. It's often difficult to reduce that, which is why we work on that inflammation, which is why if we can take some ibuprofen and knock these guys down a little bit before it gets out of hand, it'd be a good idea. And I was in the lab talking to somebody yesterday about rice. Yes, okay. And how like there's kind of this shift from rice now, which is, we're going to talk about rice in a second, so maybe I shouldn't get ahead of myself, but I'll save it for then. I'm going to stay on track. But that's the primary response to tissue injury. And the secondary response occurs from cell death caused by a blockage of O2 supply, especially with prolonged inflammation. You get increased blood flow, you get increased oxygen, you get cell death. And although inflammation does result in dysfunction, without it, the area wouldn't be able to heal, because the inflammation is all those white blood cells and phagocytes and all the other stuff that go in to help clean it up and start the healing process. So inflammation is a good thing for a little bit of time. So during our phases of healing, phase 1 is our acute inflammatory phase, aka the AKA. It's the first to occur and usually lasts 1 to 10 days. You usually get those cardinal signs of inflammation, which are what?
Redness,
Heat,
swelling. Heat, red, swelling.
Keep going to swelling pain. Alright. So that's where you get a little bit of loss of function. A to the injury, B to the inflammation, and that usually occurs secondary to trauma or a disease process. It's critical to the healing process because without it, normal healing can't take place. That's how everything starts. You gotta have that inflammatory phase. It's a good thing. It's our self-defense. That's where you get the clot formation, phagocytosis, and it lasts until the damaged tissue has been removed or a new capillary network has been formed. So our goal for therapy during phase 1, that tissue healing, a lot of times if you look at protocols after surgeries and stuff, that phase 1, they call it the protective phase. That's all we're doing for that first one. So when you get people who have rotator cuff repair or something like that, and they come in for like the first 6 weeks, we're almost scooting around here a little bit. First 2 weeks for sure, but it's kind of slow moving because you can't do a lot. Because we want to protect it, we want to keep the pain localized, we want to decrease the injurious agents. So any swelling, inflammation, if other muscles around that area are tight, we can kind of help loosen up those muscles to not put pressure on it and prepare for the healing and repair. Classic treatment during phase 1 has been RICE, which is rest, ice, compression, elevation. In the therapy world, yes, we do RICE. That's important to help control the inflammation, things like that. But we also, our profession is a movement profession. So even when people come in and they're ricing at home, we're still getting them moving. We're still putting them through passive range of motion or letting them start some active range of motion and work our way up into some resistance and stuff like that. That's the way we've always done it. But then the reason I think a lot of people are changing this RICE mindset now is because if I'm out and I'm not with a doctor or anybody else and I sprain my ankle and it starts swelling up, then historically, everybody just rests it. They throw some ice on it, throw it up, elevate it, wrap an ace bandage on it, and then they never do anything else. And then that's gonna cause to a loss of function, a loss of mobility, things are gonna tighten up. So now, the normal world's trying to get people a little bit away from this. I tried to look up some actual evidence, and there's just not enough yet, but the general trend is people are moving kind of away from that in the general public to some of the acronyms that I found. The most common one is they're saying MEAT, M-E-A-T, which is movement, exercise, analgesics, and treatment. So essentially, that's what we do, right? We create movement, we do the exercises, they're usually taking some analgesics, and then we're treating, we're progressing that. Treatment just means we start back that strengthening process when it's time. But they're kind of putting that information out to the general public as well now more because motion is the lotion, right? We gotta keep it moving or things stop. So we still want to rise, we still want to rest, we still want to ice, compression if it needs to, but that's usually just the first 24 hours, right? To help that inflammatory process kind of calm down. Then we get into the move and the MEAT and all the other acronyms. So just hopefully that answers the question that I had yesterday. Any questions on phase one? That looks like a question. Yeah, you. Let's see.
Nope. This process.
Okay. That's the other hard part, right? 'Cause
Yeah.
you're just throwing all this information at you for 3 hours. And then, like, do you have any questions? No. But tomorrow you will. Email me. Just try it. If you gotta stop yourself, you're Dr. Christie, they're gonna So shoot me an email. Phase two, the proliferation phase. Also the fibroblastic or the repair or the regeneration phase. So during this phase, we get a little more revascularization, the blood flow starts coming through a little bit better, and those macrophages, which increase growth factors, growth factor beta. Y'all don't have to remember all of this. Growth factor beta, collagen types 2 and 3. We're not going to get that deep into it in this class. You probably will in another one. This is just, again, introduction. I just want you to understand what's happening during these phases and why the modalities help, right? That's what we're trying to get at here. So get scar formation during this phase. Again, the growth factors, the osteogenic growth for bone repair if we need to. The scar tissue is fragile at first. That's as it's starting to heal, it's not very thick, which is why when we're pushing that range of motion, as we're hitting that, they have pain before we even get to that tissue resistance. We're still developing it, right? So we don't want to push it at that point. We don't want to hurt anything. So this phase lasts from day 3 to 20 days or so, and this is where we get rid of a lot of the stuff that's been in there. The scar starts to heal. Gentle movement, again, up to that, how that hurts. Because scar tissue, even once it heals, is only 70% as strong as the tissue that it's replacing. So 70% is pretty good, but it's not 100%, which is why a lot of times after any surgeries, we're strengthening more of the surrounding musculature that helps us to stabilize that joint, because part of it's going to be less stable than it was. It's only 70% as strong as the tissue it replaces. And immobilization or protected movement is important to prevent bleeding as things are healing, and that's why people usually in the slings and stuff after surgeries. So active stress and contractions and joint mobilizations can start causing the collagen to become stronger, more functional, and kind of organize the collagen as it's coming in there, because it starts randomly. All that collagen, all the scar tissue comes in, it just starts healing like this. And the muscle tissues are running this way, and the scar just doesn't care. So, scar mobilization is another big thing as we move forward. That's another course, but movement itself kind of helps start to realign that collagen. So just moving them within that tolerable range as to not hurt anything, and then we start pushing a little bit more as things heal, so we can stretch that scar tissue along the formation of the movement that we want, and help it get a little bit stronger. Vigorous heating at this time can also cause increased bleeding and is contraindicated. So when people are still in that second phase, the regeneration phase, the repair phase, the proliferation, we don't want to be putting moist hot packs on them with some tins, right? Still want to put some ice. So this phase, we work on 3 stages or 3 steps where we get resolution, regeneration, and repair. So the resolution is the epithelialization or granulation. So the dead cells and cellular debris are removed by phagocytosis, and the original structure is left intact for function. The epithelial cells seek out moist, oxygen-rich environment, and they can only cover 2 centimeters of an open wound. So all that's happening during that resolution phase. Things are coming in, getting cleaned up. They like having a moist area to work in, an oxygen-rich environment. So you don't really want to be putting a lot of stuff tightly over all of that while we're trying to have that stuff heal. The wound contraction, where the damaged tissue is replaced by the cells of the same type, and the structure retains some of its original or all of its original structure and function. It's that regeneration phase. The myofibroblasts pull the entire wound together, and then one of many different forces that leads to a contracture and subsequent loss of passive motion is as all of that stuff is coming together and healing, it's trying to tighten everything back up, which is why it's so important as PTAs and PT in general to move while things are healing. And that's why when people don't go to therapy after, there's a lot of that mobility and function because no one stretched out that tissue while it was healing in the regeneration phase. So then the repair is where we get that collagen production finally. The original tissue is replaced with scar tissue and function's lost. The tensile strength is dependent on cross-linking, how well it connects and how well it's moved. And the weak electrostatic forces kind of hold the edges together for that last little phase. All right, now we start remodeling. Maturation process, regeneration process. Just remember remodeling. And the long-term goal of wound healing is the return to their prior level of function. So during the final phase of healing, the process here is to reshape and reorganize that scar tissue. We kind of started that last phase, we're getting moving a little bit, but now things are healed, we can start pushing them a little bit more. So ideally there should be a balance between the formation of new collagen and the breakdown of old collagen. And this could take weeks or months depending on the type of tissue, focusing here on muscle strength, increasing the range of motion, and restoring that normal function. We can do that with modalities, exercise, self-management, and if you'll notice the days on all of these things, 1 to 10, 10 to 20, they all kind of can overlap just depending on the severity of the wound and how fast people heal. So there's a range, and they often do overlap. Any questions on any of that stuff? Not today, right this moment. So, as we're healing, we talk about healing by first intention, second intention, and tertiary intention. So healing by first intention is the initial union of the edges of the wound, progressing to complete healing without a granulation. Second intention, the edges are separated. Granulation tissue develops to fill the gap with epithelial growing over the granulated tissue. And tertiary is where granulation fills the gap with epithelial growth slowly. So when we talk about healing by first intention, if you have dirt in the wound, it's one of the reasons to leave that wound open and allow it to granulate and re-epithelialize on its own. So that's healing by first intention. Okay? The initial union of the wounds progress to complete healing without granulation. If they got dirt in there, we want to clean it out and let it start to heal on its own. Infection of the wound is another indication to leave the wound open so that the infection can be treated and observed, and we let everything granulize. And then excessive drainage from a wound is another reason to leave the wound open. So healing by first intention, get everything clean, take care of any issues before that healing. We won't spend a lot of time on this again. It's just kind of a summary because you have wound care and special topics next semester, and you're gonna get a lot more detail in that, and it'll be a lot of fun. So that's healing by first intention. So we'll run through these last little bits. Let me see. Yeah, we got 10 slides left. Let's take just one more pause because my throat is getting a little sore. And then following injury, type 3 collagen is predominantly produced. Immobilization allows type 2 collagen fiber to arrange a little bit. during the early phase, active stress, muscular contractions meaning submax, isometric, or more endurance exercises, and joint motion, as in passively, allow the collagen to organize, become stronger, and become functional. So that's why we start doing some isometrics early on after tissue damage, especially ligament damage, is because that helps to start organizing that collagen, right? Everybody know what isometrics are? Any questions? Just checking. And then passive range of motion, because then we can kind of control how much they're moving, and so we're still putting a little stress, but not too much stress on the injured tissues. Ligaments are categorized as a sprain, so partial tearing of ligament fibers with moderate joint laxity is defined as a grade 2 sprain. You typically see grades 1 and 2 most of the time. Untreated sprains are comprised primarily of type 3 collagen, biomechanically inferior to the ligaments treated with mobilization. Generally not healed even 40 weeks after the injury, and can lead to ligament atrophy and reduced strength. So after surgery, the early phase with early motion followed by mobilization is to help us reduce the bloody effusion within the joint, increase the connective tissue strength, and inhibit adhesions. That all makes sense. We had some ligament repair after surgery. First thing we want to start doing is some early movement, but then for the rest of the day also keep it in the sling, keep it immobilized, so that we're increasing that blood flow, tissue strength, and limiting them to getting stuck in this position. So, early movement. Awesome. For bone healing, fracture management and healing objectives for bone is to approximate the bone fragments. Everybody know what approximate means? Put them together. Approximate. So you have a break, we want to approximate, put it back together, and maintain that alignment. We don't do that part. And then we want to preserve and restore the function. The adult skeleton is comprised of 80% compact and cortical bone. Osteoblasts are what helps synthesize bone growth, and immobilization, reduce stress, decrease osteoblasts, and increase rapid osteoclast activity. So, osteoblasts coming in to help synthesize, create more bone tissue after injury. So if you just rest and elevate and don't do anything, you slow down that healing response. So bone heals faster with a little bit of movement and with some early weight bearing as prescribed. Normal bone growth, remodeling, and repair are influenced by motion, stress, muscular contraction, and physioelectric effect. I don't know what that means, if I'm being honest. Look that up. Complications that occur with bone healing are a delayed union, a non-union, and a malunion. Does everybody understand what that means? What's a delayed union? Right, it's just taking longer, right? So we've approximated and then tied a rubber band around there or some screws, whatever. But they approximated the joints, and then that section where they're trying to get it to heal just takes a long time to create that bone growth. That's a delayed union. A non-union would mean it just didn't happen. And then a malunion would be like maybe things got a little wonky while it was healing, right? So they healed inappropriately. Capiche? Alright. Wolff's Law is the idea that natural healthy bones will adapt to and change to stresses that are applied. So with Wolff's Law, your body changes to the stress that it is subjected to. So if the bones are heavier or subjected to heavier loads, they naturally reconstruct themselves to accommodate that weight. This is how bones typically respond to stress. So not only that, with heavier weight, the bones reconstruct heavier. With, you've seen the older folks that walk around like this, because they start subjecting themselves to this, and everything starts changing the way it's shaped. And now, if you try to correct that, it probably cause even more damage. Right? Once they've been here for so long, if you like stand them up, issues, because the structures have changed, right? That's why it's so important to catch it early on and get it like now when you're your age, start working on some postural exercises so you don't end up like this down the road. Bone healing is classified by injury site, the configuration of the injury, and the relationship of the fractures in the environment. Pediatric fractures, usually growth plate fractures. They don't do, never mind, I'll say that. Osteoporosis is a common cause for pathological fractures in geriatrics. Everybody know what osteoporosis is?
Demineralization.
Huh?
Demineralization.
So it's just not getting, we talked about how bones change the structure. They use the osteoblast to help reproduce bone structure. Osteoporosis, we have less osteoblast activity, increased osteoclast activity, so there's more breakdown than there is build back up. So that decreases the quantity of bone that is in there. That's why you always hear people going to get their bone density scans and stuff like that to see where that level is, because then that's where falls or anything really, too much load of weight can cause bone damage. And the most common sites are vertebral body compression fractures. So with surgery, traction, cast braces are common methods of external fixations for fractures. ORIF is an open reduction internal fixation to help internally stabilize a fracture. Everybody knows the difference between like a cast, everybody knows a cast and a brace, right?
Mm-hmm.
Easy peasy. Anybody know what an ORIF is? Other than open reduction internal fixation.
Like plates and screws. Like plates and screws, like things that are inside.
Yes, so that's the reduction part, right? Or the internal fixation part, sorry. But the open reduction is, so now they have the plates and screws inside there to help, right? And now there's pieces that come out of the body to stabilize
Cages.
it out here. Does that make
Is
sense?
it like the cages, like on
Kind of,
feet
yeah,
and stuff?
Exactly.
Okay.
So that's an open reduction,
Gotcha.
but internal fixation. And then after a while, they'll go in and they'll take that external fixation piece off. Or you know what I'm saying? The external piece. Does that make sense? Everybody's seen something kind of like that before, maybe. Okay, they're pretty cool. So the rehab, isometrics are commonly used for the immobilized area during recovery from fractures, usually submaximal isometrics. We start pushing, we're not giving it everything we got. Active range of motion without any resistance with that, and electrical muscle stimulation can be used to encourage, stimulate, and enhance muscle contractions. We'll do that in here. Rehab is meant to improve circulation, help with fragment approximation, promote motion to the immobilized parts, and stimulate the piezoelectric effects. Yeah. The goals during rehabilitation are to improve fitness, minimize atrophy, protect the healing structures, and teach safe and effective gait and transfer patterns. Now we talk about cartilage. 65 to 80% of articular cartilage is water. 10 to 30% of the peripheral, medial, and lateral meniscus is vascular. So that's not a lot of vascular in meniscus. 15 to 20% of meniscal tears occur in the vascular border, though. So still, that's why a lot of times with meniscus, they usually first don't try to do a repair, right? Because it's not vascular, right? For the most part, only 10 to 30% is vascular, and only 15 to 20% occur in that section that's vascular. So if it's not vascular, what's that mean? You still feel it.
Maybe like kind of heal.
Oh yeah, it's not gonna heal. Yeah, there's no blood flow. There's no way for all that fun stuff to happen there. So typically, with meniscal tears, the first thing is to like live with it. Be fine. Give it a minute. But if it just bothers me, because sometimes you kind of just it cuts itself off, right? We're moving, and the piece that's torn and flapping around will eventually just like pop off. Or if it's a little bit in that vascular border, it can start to reattach. But then when they go in there, they don't do any repairs. They usually just go in there and go and cut off the piece that's torn and flapping around so that it doesn't keep tearing more. So there's not a lot of healing that happens with the meniscus. Articular cartilage is frictionless. It helps create the glide with the bones. Generally 2 to 4 millimeters thick. It's durable, meaning it's resistant to wear. It's able to dissipate a compressive load. It does the joint lubricating. It helps with load bearing, and it helps a little bit with joint stability. Articular cartilage, I always try to think of it like a sponge, right? It's like in between the 2 bones, there's that articular cartilage. So if I have a sponge and it's full of water, and I do like this with it, the water just kind of stays in the sponge, right? But if I put it down here and I press on it, water comes out of the sponge. That's kind of how articular cartilage works. So it helps fluid, it helps generate some fluid and lubricate the joints, but only if they're weight bearing. Mostly when they're weight bearing. So that's why weight bearing is such an important part in healing after any kind of surgeries or issues. Injury to the cartilage causes joint instability, immobilize. Repetitive stress can cause injury to the cartilage. Non-weight bearing leads to degeneration and loss of the protein synthesis. So that's again where we want to start weight bearing to get that cartilage healing. Increase vascular supply, and then you can have femoral or retropatellar abrasions to help smooth down the surface wherever some bony stuff can grow, not to injure the cartilage. So generally most cartilage damage is degenerative and usually occur in people older than 40. So not many you gotta worry about that yet. And articular tears can occur from twisting, torque, deceleration, and compression. A lot of those, think about like sports injuries and things like that, where we get damage to the cartilage. Typically you have damage to the ligament and the cartilage. It's a lot of fun. If tears occur to the vascular area, called zone 1, which is red on red. What does it mean by red on red? That's vascular. That's vascular area. Okay. You guys are still with me? Alright. It's repairable. Muscle and tendon healing. Any muscular tendinous junction is most susceptible to indirect and incomplete muscle strains. Concentric or eccentric contractions are frequent causes of indirect muscle strains. What's the difference between concentric and eccentric?
Shortening and lengthening. Shortening and lengthening.
What's what?
Concentric shortening, eccentric is lengthening.
Awesome. Everybody hear that? Everybody knows that? Okay, cool. Just checking. Alright, so that's typically where we have the most muscle strains, which makes sense. Not a lot of isometric muscle strains. The most profound change in the human skeletal muscle during immobilization is atrophy. What's that mean? Right. So if we're not using it, you lose it. So the amount of atrophy depends on the duration of immobilization and the position or stretch imposed on the limb during the immobilization. After most shoulder surgeries, for at least 4 weeks, they're in a sling. Usually 4 weeks. So, what would I be at risk at here if I'm not going to PT and getting stretched and letting move my arm? Some contractions in the elbow, forward shoulder, so that's get out there so we can start moving a little bit. And you're also going to lose a lot of what they do anyway. You need a lot of atrophy because they're in here for 4 weeks. Type 1, which are the slow twitch muscle fibers, atrophy to the greatest degree with immobilization in a short period, 20% increase in sarcomeres as well as proteins. Protein synthesis occurs when immobilized in a lengthening position. So the healing response of muscle is greater than bone, ligament, or cartilage. So muscle heals faster than bone, ligament, and cartilage. So with muscle and tendon healing, part of the rehabilitation is some NMES. Anybody have a clue what that means? So that's one of the things that we'll do in here. So neuromuscular electric stimulation. In conjunction with isometric contractions during immobilization, can help retard tissues atrophy, minimize strength loss, and reduce the loss of succinate dehydrogenase. With the deep muscle contusions, it's best to avoid heat, early progressive motion, or massage due to these treatments promote myositis ossificans. Anybody know what that means?
Bone grows in the muscle.
Say it again.
When the bone starts to grow in the muscle.
There we go. That makes sense. Sweet. Thanks for being here. Alright, tendons have the capacity to heal both intrinsic and extrinsic. Generally receive blood supply from the synovium and the musculotendinous junction. During rehab, less adhesion formations can be accomplished with early, limited, and protected motion. That describes a common course of rehabilitation for tendinitis. Anybody know what that means? 'Cause I don't. Look that up. I'm assuming this protect rice and then I can mobilization. Exercise. I'm gonna look it up. Okay. Basically everything we already talked about, right? That's what I thought. Tendon injuries that require surgical repair are best treated with limited immobilization, gentle and protected range of motion, and appropriate exercise, which again we've already talked about. Wasting slides. All right, we did it. Day 1 in the books. How's everybody feel? Exhausted. Me too. Any questions?